The information shared on the Sky Women's Health podcast is for educational and informational purposes only and is not a substitute for professional medical advice, diagnosis, or treatment. Always seek the advice of your physician or other qualified health provider with any questions you may have regarding your medical condition. Never disregard professional medical advice or delay in seeking it because of something you heard on this podcast. Reliance on any information provided by Sky Women's Health, Dr. Carolyn Moyers, or any guests featured on the podcast is solely at your own risk. You're listening to Sky Women's Health Podcast, your evidence-based resource for women's health and wellness, exploring the holistic principles of osteopathy, integrating mind, body, and spirit, designed to empower you as your own healthcare advocate and help you live your best life. I'm your host, board-certified OBGYN, Dr. Carolyn Moyers.
What if rashes, hives, sinus flares, food reactions, and random inflammation that showed up in midlife aren't random at all? On today's episode of Sky Women's Health Podcast, we're talking about the immune system in midlife and why some women develop new allergies, food sensitivities, and sometimes mast cell activation symptoms during perimenopause and menopause, and what's actually happening beneath the surface. I'm joined by Atoosa Kourosh, award-winning board-certified pediatrician and allergy and immunology specialist with advanced training in public health and integrative medicine. Dr. Atoosa is the chair of the American College of Allergy, Asthma, and Immunology's Integrative Medicine Committee, and she brings a rare ability to bridge experience-based medicine with whole person care. We'll explore why a woman may suddenly develop a peanut allergy at age 51 and how hormonal shifts influence immune regulation and when symptoms like flushing, itching, GI upset, and unexplained reactions may point to mast cell activation. If you ever thought, my body didn't used to react like this episode is for you. Welcome, Dr. Atoosa.
Thank you. It's so great to be here. I've admired your podcast for many years, Dr. Moyers, and it's my pleasure to be here.
You should have asked to be on sooner because it took me a couple of years to put the connection together and ask you.
Well, I'm here now and hopefully not the last time. So
That's right.
This is a great topic, though. I'm excited.
Same, because this happens so often. And I was like, wait, I know who to talk to about this. I have enjoyed collaborating on several patients with you. So
yes,
thank you for being here.
My pleasure.
So let's talk about why this conversation really matters in midlife. There's new onset of allergies and sensitivities often in perimenopause and menopause. I never will forget a patient who's like, oh my God, now I have a peanut allergy. I'm like, oh my God, I have you on micronized progesterone. I'm going to have to change your progesterone because of your peanut allergy. So there's an overlap between the immune system and everything feeling off in midlife. Talk to me about that.
Yeah, it's so interesting that you shared that patient anecdote because that's actually something that brought one of my patients in, is when she was started on an estrogen, a progesterone supplement. Actually, it was a combined supplement, and she started reacting. So we had to figure out what in her medications and supplements she was reacting to, and it turned out that that was it. And when we switched her to the yam-based progesterone, she did not react. So that's actually a great little tidbit. But okay, so we've known for a long time. The research came out in the 70s and 80s, actually, that showed, and it wasn't even in perimenopausal women, because honestly, they weren't really being studied until recently, as we well know. But it was found that women who had chronic urticaria or other kinds of allergic diseases, and this was women of reproductive age who were menstruating, around the time of their period in their early follicular phase, while estrogen was rising, they would have a flare of whatever their issue was, whether it was chronic urticaria or seasonal allergy or eczema or other things. So it actually began a pathway of questioning about whether hormones could play a role in activating the immune system, and generally became accepted that estrogen did lower the threshold for some immune reactivity. And we know as women approach midlife, first to decline is actually progesterone and testosterone, leaving estrogen dominance as a factor in perimenopause, where estrogen is still being made in high doses or high levels in some women. And
Often just erratic levels, we're high
erratic
and we're low,
levels.
we're high and we're low.
Exactly.
It's all
So
over the place.
unpredictable.
Yeah.
Exactly. And
Yeah.
that can actually lower the threshold to immune reactivity. And so a lot of times, if they had a predisposition to an allergic disease, it becomes more prominent. So many women have actually told me, even with seasonal allergies, that it never used to be much of an issue. They would take an antihistamine, but fine. And now they're so miserable that it's affecting their life. And they go in and ask their doctor for a steroid shot or something to get them through the allergy season. So, which also, presents other problems.
Yeah.
But yeah, so that's part of it. And the other is that that menopause and perimenopause bring with them microbiome changes. And you and I both, having studied integrative medicine, know that the gut is actually a key immune regulator. It's where some neurotransmitters are made, some hormone regulation happens in the gut, and actually, it's one of the keys to training the body for tolerance. So you having the right microbiome trains the body to tolerate its environment. And people used to think that food allergy only happened in childhood, that it was a result of something that happened in early life or genetics, and that you developed food allergies in early childhood. Well, while the vast majority of that is true, you can develop an allergy at any time during your life. You can have a food allergy develop at any time during your life. And it has been linked to microbiome disturbances. So we know that changes in the microbiome that can happen with perimenopause and menopause can predispose you to the kind of gut inflammation that can lead to food allergy formation. So it is not unusual to develop new food sensitivities and new food allergies in perimenopause and menopause.
I see this often in my practice, and very likely because I'm seeing the midlife women who are going through that transition, right?
Yeah.
But, not many people are paying attention to it. So often women are dismissed or it's misattributed to stress or anxiety.
Yeah.
And they're left wondering, how to get to the bottom of this.
That's a really good point. And I think that one of the main things we both offer in our practice is that we listen to our patients and we do not dismiss symptoms and signs that are real, attribute them to only stress. Because honestly, when do we not have stress in our lives? I think to attribute something to stress is to say that, you can now change your life and make it less stressful, and therefore you won't have this problem. And realistically, that's not a possibility for most people. They live the life they live. They have the job they have. They have the family life they have. They have the schedule they have, and very few people can choose to be an ascetic or go into the mountains and chill long term. So it's not. We can try to increase our nature time. We can try to decrease our stress, but honestly, we need to manage the patient and their environment. And we often cannot drastically change their environment, except for, when there's toxic things that we try to take them out, right? So
whether it's toxic people or
toxic people or toxic
plastics
things or mold exposure or
Sure. Yeah.
or whatever their environmental exposure is, we can try to modify it. But honestly, we need to look at the body system as contiguous with the environment, and it's all one system. So the body and the environment that the patient lives in, it's one system, and their body is not separate from their life that they're living. It's reacting to the life that they're living. So I'm a test don't guess kind of doctor. I definitely get allergy testing when it's warranted. And often my midlife women, they haven't really had a good look at their hormones either. So they ask me to do that. And it's sometimes difficult to do that because if they're not menstruating or if they're menstruating erratically, it's difficult to time the hormonal draws. But I do my best and I refer them many times to you, Dr. Moyers, or I, ask them if they have a healthcare provider that's knowledgeable in hormones to look at that. But I focus on their gut and their allergies and trying to figure out if their immune system is functioning normally or hyperreactive. And that brings us to this mast cell activation question, which happens In a lot of states, honestly, one of the most common triggers for mast cell activation is an underlying mist infection, a chronic infection like a yeast
Can you
infection.
explain what that is? Because I think a
What
lot of
mast
people
cell
are familiar
activation
with
is?
mast cell
Yes.
activation. Yeah.
So I think it's becoming more talked about, but it was generally, I feel like, almost unknown. Like I had never heard of it till I went to allergy fellowship, and I went to allergy fellowship in midlife. I was out in practice as a pediatrician for 10 years, and then in middle of my career, I went back to allergy fellowship really to do the microbiome research that I
Mhm.
did with respect to the food allergy and its origin in the microbiome, which I alluded to earlier when I was talking. But but and there are specific food allergies, there are specific microbiome derangements that lead to food allergy formation. But when I went back to allergy fellowship, I heard of this mast cell activation syndrome and mast cell disease entity. So mast cells are the cells that produce histamine. So a lot of people have heard of histamine, which is implicated in the allergic response. And it's often the last thing that happens before allergic responses happen. And allergic responses can be anywhere from hives or flushing, itchiness of the skin, swelling of the mouth and throat, or eyelids. And it can also lead to abdominal pain, vomiting, and all kinds of gut disturbances when there's a high histamine release. And these mast cells are everywhere. They're in our skin, they're in every mucous membrane, like eyes, nose, mouth, all along the gut. We have mast cells. And there are other places in the body where wherever we interact with the environment, mast cells are there. And the reason is that they were the sentinels of the early evolutionary immune system. So when human immune systems evolved, mast cells were standing guard against parasites and other kinds of invasions. And they were originally, we think, evolutionarily designed to release histamine in the presence of infectious agents. So whenever an invader would come in, these mast cells would release their activated granules. So these, imagine these cells with these immunoglobulins or proteins on their surface, and these proteins get, touched by the invader. They're recognized as an invader and not a body cell. And then the enzymes that the mast cell is holding inside get released, and that includes histamine and several other products. And that calls other immune cells, white cells and other immune cells to the area. It calls help to the area, and other body systems that are designed to fight parasites and bacteria and yeast. So that was how they were designed for the body. But that's why any kind of chronic infection, which chronic infections can be anything from something overgrowing in the gut to a parasitic infection to chronic yeast infections, which a lot of women have, especially if they have higher estrogen. It can predispose to yeast infections, or erratic estrogen even can. And so all of those can be the potential trigger. But there can be other potential triggers like autoimmune disease, even food allergy, and even out of control, rampant environmental allergies. We think anything that can overstimulate the immune system and cause mast cell degranulation or mast cell release of its enzymes can eventually lead to this vicious cycle where mast cells get even more sensitive and release very quickly. And some people find relief with just antihistamines, but most of the time, the body's capacity to handle that histamine, to process it, to break it down, is overwhelmed by how much is being released. And antihistamines don't make as much of a difference
Yeah.
and are ineffective. So some people come to me and say, I have hives every day, even though I'm taking an oral antihistamine.
Yeah. I mean, I've had patients report flushing, itching, hives, the GI
Exactly.
symptoms, bloating, diarrhea, nausea, brain fog, headaches, anxiety-like
Correct.
symptoms. And so we wonder why, many MCAS patients might be missed in midlife. Well, because perimenopause, I mean, there's so many symptoms because we have estrogen receptors throughout our body. There's
Exactly.
so many symptoms that can um, mimic it, right? And so that's why I always say we have to look at underlying causes first, because there are many things that can masquerade as perimenopause.
That's true. And even if there is perimenopause, it doesn't mean that there isn't a distinct other chronic infection or something. And I've found UTIs, nail fungus, like I said, gut microbial disturbances, nasal pathogens and sinus pathogens. I found all kinds of things in these patients where when I treat the infection, everything simmers down. But we have also now come farther in our diagnostic criteria and our treatment possibilities. So to diagnose mast cell activation, which is different from mast cell disease, because mast cell disease is more about a genetic mutation that leads to an abnormal mast cell formation, and also lots of mast cells being formed, way more than the normal human has.
So is that somebody who would have had it since childhood?
Yeah, they might have had things in childhood, but sometimes it presents in midlife, even though the tendency of it was always there. Or they had isolated symptoms, but then the cluster of symptoms came together to help make the diagnostic criteria. So, and the diagnostic criteria for mast cell activation syndrome, or MCAS, is the major criteria, which is to find an abnormally large number of mast cells in tissues. There's only three places to look for it in tissues: skin, the gut, and the bone marrow. Now, bone marrow is very invasive. Like, it's, associated usually with like cancer treatment to have a bone marrow biopsy. And most patients aren't willing to get a bone marrow biopsy, even
nobody's
if they
signing up for that.
Exactly. So really only in research settings has that been done. But the gut, often these patients have a lot of gut issues, and they might get endoscopy done. They might get a scope. And if they're going to GI and getting that, we can actually sometimes even retroactively have those biopsies examined under the microscope with special staining to look for mast cells. And if they meet the criteria for abnormal numbers, then that's a major criteria for diagnosis of mast cell. Then there's 2 or 3 other minor criteria, and one of them, and you have to meet 2 of the minor criteria. So one of them is to prove that either in the blood or the urine, there's abnormally high levels of those mast cell enzymes that I talked about, like N-methylhistamine, and there's leukotriene E4. There's several of them. So and we now have the testing capability to test for those in both blood and urine. And the most sensitive is really 24-hour urine. So collecting urine for 24 hours and seeing if over a 24-hour period, there's an abnormal increase in the secretion or the excretion of those mast cell enzymes. And that's why, because it can be spiking and then lowering, that 24 hours helps us catch a flare or catch a high level. And then the other is having the other criteria is having the symptoms, a lot of which you mentioned, right? Like hives. And there's even other ones like passing out, or we call it fainting, dizziness. There's many other ones too. So there's actually a cluster of mast cell activation symptoms, about a dozen, that if you have, say, more than 6 or 7 of them, then that's sort of points you towards the diagnosis. And then there's, if you put them on mast cell stabilizing medicines. So antihistamines are one of them, but there are compounded medicines like ketotifen and cromolyn that can be made by compounding pharmacies and are usually being prescribed by allergists, but some integrative medicine doctors also prescribe them who don't have allergy training. But when the patient takes those, do they see a symptom resolution? And then the 4th minor criteria is c-KIT mutation. So it's a mutation in the mast cells that would predispose to both mast cell activation and the mast cell diseases that I mentioned. But again, that's a minor criteria, because the vast majority of people with mast cell activation syndrome do not have a c-KIT mutation. So, but if you have a mutation, which that can be a blood test, often you have to really fight insurance to get that blood test approved, but I have fought for it and haven't had it approved successfully. And the good news is that if you have that mutation, there's directed medications, biologic medications that actually target that mutation and can lead to full symptom resolution. So
that was exciting.
Yeah. So, but as you can see by what I've just explained, the workup or the investigation is extensive.
Yeah,
and so
for sure.
If your doctor doesn't know how to do it or is unwilling to pursue it, you might be left with no diagnosis for many years. And that's what I see often when patients come to me. I'm the 6th, 7th, 12th doctor
right.
they've seen.
I think it's so important to get that second opinion when you feel like you're being dismissed, and look for somebody who's trained in allergy.
Yeah.
Okay, let's talk about how allergists evaluate new onset reactions. So, not specifically, mast cell syndrome where they feel, all these symptoms throughout their body, but maybe like we were talking about a new peanut allergy, et cetera. If somebody's developed a new onset of reactions, what does your typical workup look like? Like, I'm sure there's some limitations of testing and that clinical history really matters, but kind of walk us through what that looks like.
Yeah, and that's a great question. So, one of the testing questions that you have to ask is how long has it been since your reaction, and what kind of reaction was it? So, if it was an anaphylactic reaction, like a full-blown allergic reaction involving more than one system in the body, where maybe the patient had dizziness, a drop in blood pressure, throat closure symptoms, mouth and tongue swelling, hives, difficulty breathing and wheezing in the lungs, if there was anaphylaxis and the patient needed to be treated with, hopefully they got treated with epinephrine, which is the drug of choice for treatment of um, um, of an anaphylactic episode. And sometimes the first time the patient doesn't have an EpiPen or, an epinephrine auto injector, and they hopefully end up in urgent care or ER and are treated appropriately. Although many times we have data that says that less than 50% of the time are people really treated appropriately with epinephrine, even if they're having a full-blown anaphylactic reaction. And that's a topic for another time. But um, often they're treated just with high-dose antihistamines and steroids, which are not the first line and take longer to work. So epinephrine can work within minutes, and those others take 45 minutes to an hour, with the steroids 2 hours to work. So, and they don't stop the anaphylaxis. So depending on the level of reaction, you have to decide whether you're going to test right away or wait to test, because there is data that if you've had a severe allergic reaction like anaphylaxis, you can actually use up the immunoglobulin that has specifically been sensitized against peanut or whatever the new onset food reaction was. And then if you test in that window of 6 to 8 weeks, you might get a false negative test because all of that immunoglobulin has been used up, and it takes time to manufacture high levels again. So if someone has had an anaphylactic episode, sometimes we suspect what food it was or what the trigger was. Other times we don't. When we don't have a suspected trigger, then I just give them an EpiPen and say, if this happens again, then use this and go to urgent care. And in that moment, also get certain blood tests done in the ER or the urgent care. And I give them a little handout about that, because there are certain things that in food reactions don't get elevated, but in other types of reactions like drug reactions or anaphylaxis triggered by other things like stings, like bee or fire ant stings, or drug or chemical exposures, those we can actually tell by testing certain things in the blood if what kind of anaphylaxis it was. So I give them that. If we have a suspicion, like in your patient who had a peanut allergy, maybe she was having milder reactions, like maybe just hives or stomach upset when she would take the progesterone. If that's the case and it hasn't been a full-blown anaphylactic reaction, I can probably test anytime. So maybe they've already stopped that agent. It doesn't matter. We can test with blood tests, skin tests, and those are the two most common and the highest yield tests. And that looks for immediate type allergy. But there are delayed type food sensitivities and allergies as well. And those are tested through different mechanisms, sometimes blood, and sometimes we actually look in the stool to see if there's immunoglobulins in the stool against that particular agent. And that happens a lot with gluten and other foods. And then there is another type of food allergy called eosinophilic esophagitis, which is a combination of immediate and delayed type. And that really can only be diagnosed by endoscopy. So when people have a GI predominant symptom complex, sometimes we have them go to GI and get endoscopy to make that diagnosis, especially if they're having difficulty swallowing or any of the other key symptoms that are associated with eosinophilic esophagitis. I always tell people there's 5 or 6 different ways to be allergic to foods. And what we often think of is only the immediate type or the IgE mediated, which is manifested in hives and rashes and flushing.
Girl, I feel like you have to have your detective hat on. Like,
I always do have it on.
this does work.
Medical mysteries are sort of my thing. And I think it was partly because I had so many medical mysteries and it took so long for my food allergies to be diagnosed. in my young adulthood. Once they were, it elucidated why I had so many problems and so many issues in my childhood and teens that couldn't really be addressed by all the medications that I was taking. And the integrative approach helped me. And I was lucky enough to find physicians who were curious enough and patient enough to look for my true underlying diagnoses and help me figure that out. And now I try to pay that forward to my patients.
I love it. I love it. You became the doctor that you needed.
Exactly.
So you've mentioned several, it's going to depend on the particular cause, the particular etiology as to what, evidence-based medical therapies would be approached. And that is like well beyond the scope of this podcast. But I want to talk about some of the integrative strategies that may support immune system, whether it's lifestyle, nutrition, stress, physiology, nervous system regulation, and what not to do.
That's a terrific question. There's so many things that you can do in your lifestyle. We know, for instance, sleep is one of the biggest impactors of the microbiome. And as I said, the microbiome is where the decision is made whether to tolerate something or become allergic to it, right? So, and we know that even as little as one night's missed sleep, we as doctors have had a lot of nights of missed sleep, right?
Of missed nice sleeps.
One night of missed sleep can have microbiome derangements that can be detected on a stool microbiome analysis, can lead to the potentiation of the overgrowth of certain bacteria that trigger autoimmune disease, can lead to the drop in certain intestinal health markers that need to be there, like enzyme production. So we know that sleep is huge. And a lot of people have disturbed sleep, especially in perimenopause and menopause. That one of the things that's impacted is thermoregulation, or like controlling temperature, body temperature, and that often disturbs sleep. The hormonal fluctuations themselves can disturb sleep. And then if you're dealing with an allergic disease, that can disturb sleep because it can lead to nasal congestion, itching, other things that lead to not being able to get a good night's sleep. So addressing the underlying themes of what is going on with sleep and whether the person is getting a good solid 7 to 8 hours of good REM cycles and good deep sleep, that's one of the things that you can do that's a positive lifestyle factor. And you can also like make it a point to not doom scroll at night, because that can disturb sleep, and it's the temptation for all of us, right? Because we didn't get to check our social media during the day. We were very busy. And then suddenly it's 11 o'clock and we are scrolling through TikTok and Instagram and Facebook, and the news of the world is so disturbing that leads to sleep disturbance. And I've been there myself. So having the discipline to turn off media to potentiate sleep, getting morning light and grounding, with your feet on a natural environment, especially in the morning, can help with setting you up with sleep. Short courses of melatonin, longer courses of magnesium if you need it to help you with sleep. These are all things that you could do that are low harm, high yield interventions to help with sleep. And then the other thing with lifestyle is that we know also that certain enzymatic functions, especially hormonal production and hormonal breakdown, are influenced by mechanisms in the body and pathways in the body that are impacted by mind-body exercises. For instance, there's 2 enzymes well known for impacting the dopamine pathway, and the MAOA enzyme and the COMT enzyme, which also impacts methylation. And both of them are very important enzymes in breaking down high estrogen, for instance. So if you have big estrogen fluctuations and your COMT enzyme is impaired, then it's not going to break down that large fluctuation of estrogen. Same with a large fluctuation of stress hormones. Suppose you had an incredibly stressful day at work and you had to put out a lot of fires, deal with a lot of conflict and manage things. Your stress hormones are going to be elevated. Your adrenal stress hormones will be elevated and your cortisol will be elevated. And these enzymes that I mentioned, which can even be impaired because of genetic pathways of impairment, they depend on the breakdown of those neurotransmitters and those hormones depend on the functioning of these enzymes. And there is data that yoga, meditation, breath work, mindfulness practices actually mediate and control these enzymatic functions. So I'm not saying that you can, de-stress completely by adding meditation or yoga or something to your life, but it definitely helps. Having a daily mind-body practice of some kind, even if it's just 5 minutes.
Agree completely. Yeah. Sometimes whenever we're so stressed, our autonomic nervous system is just in overdrive. We're in that
Exactly.
fight or flight. And how do you bring yourself down to a rest and digest? Um, Okay, you mentioned cortisol, and I've got to ask you about cortisol because everybody wants their cortisol tested, and I never catch it misbehaving. And so, we all think that our cortisol is elevated, but I often don't catch it misbehaving. I think a lot of it is our stressful life. Talk to me about that a little bit.
Yeah. So, I think the thing is, how are you measuring it is one thing, and you might be doing a Dutch hormone assay, which does it like a 24-hour or 72
I don't do
hour.
any Dutch testing. I feel
Okay,
like
yeah,
it's a waste of
I
money.
don't either. I don't either. Honestly, I understand its usefulness, and I've had it done on me, and I've evaluated it in other patients, but I don't usually order it. So the way that I evaluate cortisol is AM cortisol. And that's because a lot of my patients present with chronic fatigue.
Mhm.
And when you have chronic fatigue, sometimes it's that your adrenals are not ramping up your cortisol appropriately in the morning because they've just been the cortisol has been used up in the stress pathway so much that it is the response has been blunted, and the 24-hour cycle of cortisol production has been thrown off. And a lot of these people, if you do an AM and a PM cortisol on them, they're flipped. So at the end of the day, you have high cortisol, whereas you're supposed to have that at like 8 in the morning to help you like awaken and have energy for the day. You're supposed to get that cortisol rush in the morning so that you get up and go. And a lot of times if I do an AM and a PM, instead of the morning being ramped up, the nighttime is ramped up. So comparing that can sometimes help. So sometimes when we don't catch them misbehave, it's because we're not doing the exact testing that person needs. But I have seen it. I've seen both high and low. And I would say that the people who present with lower cortisol are either people who have had a lot of steroid therapy, like they've had a lot of uncontrolled asthma or been treated inappropriately for allergies with a lot of steroids, or been treated with steroids because they had respiratory issues like pneumonia or bronchitis. And I feel like a lot of, these kind of minute clinics and urgent cares, sometimes they pass out steroids like it's candy. And as an immune system specialist, I'm very
Yeah.
wary of treating with steroids. Like I'm not
Sure.
saying I never use it, but I know
Sure.
how it can suppress the adrenal gland. So
Yeah. Well,
so
that's not
part
my
of it.
typical patient, So,
Right. But high cortisol I
yeah.
have seen, and honestly, most of the patients I've seen it in are menopausal or perimenopausal women. And
Interesting.
sometimes it goes with other kinds of dysregulation, like liver enzyme dysregulation. So there's something in the body creating a toxic load, and that the adrenal response is elevated, and the
Yeah.
cortisol is elevated in that case. So it's
Yeah.
almost never just attributed to stress. So that's the
Sure.
other thing is people are like, oh, your cortisol is going to go up here because you're stressed. And I think that happens on a micro basis, but maybe not in a way that we can find an elevation in the lab.
Yeah. Well, I think that this conversation is just so enlightening because it's so out of my wheelhouse. So I love you for coming on and helping us to understand this better. And I think it's just validating for women to know you're not crazy. It's not all in your head. If you're having symptoms, please advocate for yourself to get the help that you need.
Yes.
Yeah.
Yeah, I think that's really true. And you can read about mast cell activation online. There's a particularly great blog post called Mast Attack. And I think it's mastattack.com or .org. Or maybe both of them actually. And it's by she's actually a research scientist who herself has mast cell disease. So she has gone in depth and really done the work of teaching you how to advocate for yourself, when to get referrals, how to get a referral to someone who knows how to manage it and test for it. And
Perfect.
so I think the criteria I outlined verbally are listed in very
Yeah.
clear ways, and how they've evolved over time. Like when mast cell activation was first recognized in the 80s, what were the criteria? And then, how has it changed now in the 2020s? And what do we look
Fascinating.
for? I think all of that is really valuable.
Yeah.
And there's questionnaires that you can take to say, okay, these are the symptoms that I have, and I don't have these, right? So it's good
Yeah,
to,
you could take that into your appointment. Yeah.
exactly.
Great
So
points. Great points. Well, thank you for listening, everyone. If your body is suddenly reacting in ways it never did before, don't ignore it. You deserve answers. New allergies, mast cell flares, or immune shifts in midlife are real, and there are ways to get relief. So listen to your body, ask the questions, advocate for your health. Until next week, be well. Thanks for listening. This episode is sponsored by Sky Women's Health. If you love this episode, follow the show so you never miss one. Share it with the women in your life and help more people discover it. Let's make it binge-worthy.